we'll go ahead and get things started here. We'll keep adding participants as they join. I appreciate everybody getting started. Just a quick kind of shameless plug for the Robotic EP Fellowship Program. This is one of the most aspirational things that I think Stereotaxis does. We're truly committed to the future of robotics and EP, and everybody kind of comes to robotics in a different stage of their career. We have attendings that we work with on a daily basis that just didn't train on it in their fellowship, and we're able to seamlessly adopt that to their practice for a host of procedure types. The opportunity to train over the course of 2 years is a huge one for us in our academic centers, and I think the three gentlemen that are on today are great evidence to that opportunity kind of coming to fruition. And we're seeking to expand that across more academic centers and really targeting each fellow throughout that 2 years. And ultimately, we would like to help them with their opportunities in the field, not only to create early peer networks, but to help them in finding opportunities in employment and early opportunities to share what they're doing in clinic, whether that's presence on stages at symposia, or just helping them interconnect with research opportunities, et cetera. So this is something that we haven't done, in the first 10 years of the Stereotaxis experience, but we're highly focused on now. And we thank this group for their leadership, and we thank them for their participation on this. So with that, let's get things rolling here. I'll hand it over to Dr. D'Souza, who's one of our esteemed attendings from Penn Medicine, assistant professor of clinical medicine there, and our fellow participants, Dr. Guss from Deborah, Dr. Vivek Reddy, the other Vivek Reddy. At some point, you may have to go for a name change there. I'm not sure, or eclipse the New York Dr. Reddy with everything you do professionally. And Dr. Madaj from Mount Sinai Morningside. So thank you, gentlemen. With that, Dr. D'Souza, I'll hand it over to you.
Thank you, Jimmy. Thanks, everybody. Good morning. It's good to see everybody virtually. So we've been kicking around this idea for a while. When I was, so just a little bit of background, I did training at the University of Pennsylvania. I actually did medicine and pediatrics and was going to be a pediatric cardiologist. And then somewhere along the line decided I wanted to become an electrophysiologist, took a couple of left turns, and then ended up again, doing all my training at HUP, the Hospital University of Pennsylvania. And now I'm currently still at Penn Presbyterian. I'm, I think, like 7 or 8 years out of training. As Jimmy had mentioned, this didn't really exist when I was a fellow. And to be honest, I got very little exposure to stereotaxis and robotics as a fellow. I did maybe 2 cases. And when I came to Penn Presbyterian, there was a magnet there that was largely gathering dust, and didn't really have any experience, didn't really think that I needed it. I did probably more VT ablations and PVC ablations and AFib ablations than anyone in the country as a fellow, and felt very confident manually with my hands being able to do everything. But after conversations with some other folks and with the folks engaged with stereotaxis, we started a process. And now over the course of the years, I use it pretty much exclusively for a large number of my cases. I have good outcomes and good safety. But if I had had some exposure early on, it probably would have been even better for me in terms of transition. For most fellows, I generally recommend not trying to, reinvent the wheel when you become a brand new attending, which is what I did when I started. But again, more exposure to technology and different ways of doing things, as I'd mentioned earlier, dissemination of information is important. Now, I do want to say that I want this to be as open and interactive and ask as many questions and engage as possible. When I was a fellow at HUP, it was a little different than it is now, but certainly was very intimidating when we would present cases. We presented every single case every day. And a lot of us would largely put our heads down because we were worried about being embarrassed or asking something stupid or being ridiculed in some aspects. And that sort of academic hazing, I do not think is appropriate. And I want this to be as open and engaging as possible, because we're all just trying to learn from each other, to be honest. And I learn from doing this kind of stuff. And certainly everybody does. And it's fun. And that's what I want it to be. So with that being said, why don't we get going and start talking about some cases. And again, I think in terms of questions during the presentations or any comments, it's probably best to ask it in the chat or in the Q&A, whichever Jimmy and the folks want to do. And then we'll open it up for discussion in between each. We'll try to keep each one to about 15 to 20 minutes so that I can let you guys go off and enjoy the rest of your Saturday. As much as I would like to hang out and do this for most of the day, we all have families, and I got to join my kids on the boardwalk and go on some amusement park rides and stuff like that. So,
Nice.
so let's get started. So I think Adam, you're first up.
Yeah, let me do a little screen sharing here and take over from there. Let's see if get this together. Let me know if you can see that. That looks okay?
Yep, looks great.
Okay. I'm going to minimize this just to get that out of the way. So hello, my name is Adam Guss. I'm a second-year EP fellow at Deborah Heart and Lung. I did my cardiology training as well at Deborah Heart and Lung, and I'm very thrilled to be here to present what I find has been a very interesting sort of process of what I call optimizing magnetic navigation when we're doing retrograde aortic pulmonary vein isolation. I have no disclosures, just throw that out there. From a background point of view, I'm going to throw some information I think we all know pretty well, but I just always like to start with a little history to things. AFib is the most common arrhythmia, with an estimated about 12 million people being affected in the United States by 2030. AFib is associated with a 4 to 5-fold increased risk of ischemic stroke and a 1 in 7 cause of stroke, so as a general balance of things. With advances in technology and healthcare over the years, we've obviously moved in the direction after Cabana to the point where treatment options are now including not just medications, but also procedural aspects like pulmonary vein isolation as a first choice for some patients. Pulmonary vein isolation via transeptal atrial puncture in the setting of AFib is the most commonly used technique to perform EP procedures in the left atrium, but not all patients have viable anatomy for transeptal atrial puncture. As a general example, which will come up a little later here, azygous continuation of the inferior vena cava, sometimes referred to as congenital absence of the inferior vena cava, is an uncommon vascular anomaly with a prevalence of approximately 1.5%. And it's often an incidental finding. It's also not the sort of incidental finding you may want to find out on procedural day. With 33 million people affected by AFib worldwide, it's inevitable that at some point patients with complex anatomical conditions will be affected. When we will talk about reasons to go retrograde, atrial septal closures, congenital anomalies, IVC agenesis or malformation, and other causes may all result in an atypical anatomy to attempt transeptal access. Retrograde aortic access to the left atrium has been previously described in literature, but it's not commonly performed. In literature review, we've noticed that there's always some mention of a significant difficulty in achieving the transmitral crossing from the left ventricle into the left atrium. And manual catheter manipulation is nearly impossible to perform this. So robotic magnetic navigation really has offered a unique tool set to maneuver through the aorta, pass through the aortic valve, flip back around and find our way through the mitral valve apparatus into a stable position to map and then subsequently ablate within the left atrium. Our case was a 64-year-old male with a past medical history of recurrent symptomatic paroxysmal atrial fibrillation who was referred to us for pulmonary vein isolation. He had a complicated cardiovascular history, primarily relating to a congenital secundum state with significant left to right shunting, with progressive biventricular enlargement, and mild left atrial dilatation. While undergoing workup for closure of his ASD in 2016, they did a little venography and found out that the IVC was actually interrupted. Despite this, he actually underwent a successful ASD closure with a 24-millimeter Amplatzer occluder via transhepatic vein access. Our patient, however, struggled with their AFib symptoms, including shortness of breath and palpitations, and they were refractory to medical therapy. They did not do well on just antiarrhythmic drugs. We had a few drugs that ultimately they were unable to tolerate. The patient was then referred to us for pulmonary vein isolation, discussed the IVC anomaly as a secondary options. We decided to go with a retrograde aortic approach, and subsequently the patient came to the EP lab. I'm going to jump into a couple pictures at this point, just because I think they tell quite a story. First and foremost, we've got a duodecapolar catheter here within the right atrium and into the coronary sinus os. We did this access from the right femoral vein, and the duodeca was actually passed through the enlarged azygous collateral, allowing us to reach up and over and come in with what looks like a superior access approach. You can also clearly see the 24mm Amplatzer device, which dwarfs the right atrium here. It's a very large device. It's kind of a thickened bicable sort of disc approach. It is something that in literature has been shown that you can cross this with some difficulty, but without an IVC to get leverage, or that's not necessarily something extremely viable. So the retrograde aortic access seemed like we were primed for here. We got access to the right femoral artery, and from there we swapped over a wire and ended up with an SL1 sheath placed within the aortic valve for catheter support. Directing that posteriorly, you can face the mitral valve. The aortic valve can be crossed with the RMT catheter prior to its placement in the drive, subsequently kind of an attempt at prolapsing it, sometimes bringing in the magnets and applying a vector is enough to get across. One way or another, find ourselves within the left ventricle. From there, you kind of run into the difficulty of the case. So transmitral exchange, I think, is the best terminology for this. And that is that there's a bunch of technical challenges. From the point of view of facing from the aortic valve to the mitral valve, the entire mitral apparatus, including the papillary and chordae, are sort of in your way. So even with robotic magnetic navigation, entanglement within the papillary structures of the mitral valve often occurs, provides a significant obstacle to advancement. In addition, the mitral leaflets themselves offer an impediment. So when you're coming in the retrograde approach, you're kind of coming into the parachute pouch and you can get caught pretty easily. In this case, we tried something a little bit different. We determined we wanted to try and map the left ventricle first. So we decided that if we map the left ventricle, specifically looking at the mitral valve, we may be able to improve that mitral ingress over fluoroscopic visualization alone. Using the RMT thermocool catheter, we took a bunch of positions around the mitral valve, added that to our FAM shell. And subsequently, we had a good map of where the mitral valve was, and we kind of just used that as to guide our approach. From there, we attempt to circumvent the papillary muscle by really taking the catheter down to the ventricular apex, and then attempting a rapid change in vector aimed at the mitral os with enough slack that it can pass through the mitral apparatus. Some things to consider if your patient didn't necessarily not have an IVC. This might be a little bit easier if you had intracardiac echocardiography, but an ICE or a sound star could allow you to map internal structures. You could add the papillary muscles in and see if that helped to even open up the map even more for those structures. But that's a relatively stiff catheter, and we didn't feel like we wanted to try and pass that through the azygous and try and flip it all the way over, or pass it through a long sheath and bring it in from a superior approach. Just ended up feeling like that'd be a little bit extra complication. While this image is not taken from this patient then, because we did not use an ICE probe for this case, it's a good example of the anatomy you're facing. From here, we have kind of the, from the right ventricular position aimed to the left ventricle on ICE. We have the left atrium, we have the beginnings of the mitral apparatus in two views, the beginnings of the LVOT and the openings of the aortic valve. We're coming in retrograde, so we're coming in from this position. From this shot, it seems like you could just come right through and pop into the mitral valve. But in actuality, with every systole, you have a significant amount of mitral apparatus, papillary muscles, and chordae, all of which are going to end up either you're going to pass through those chordae and find yourself entangled and now at the whims of the movement of the heart itself during systole, or it's just not going to allow significant passage and actual ingress through the mitral valve. So we took points. We started with mapping as we could around the mitral valve itself. We mapped and took certain points that we sort of marked as being our best representations from this position. And then knowing that, we find that we have really two cavities that we can determine that we assume are really our papillary muscles. And then we can try and take a position both fluoroscopically and from a cardo point of view and pass through the mitral valve as easily as possible. It's still a little probabilistic in that it still takes a few attempts, often where you get enough slack into the left ventricular apex. This is coming through the aorta, passing down to the ventricular apex, building up some slack here, and feeling though that the catheter itself is relatively running the outer wall here, which means we're not entangled in the papillary structures of the mitral valve. and then taking a few attempts to transition it rapidly towards the mitral valve to try and find and catch the opening here. But it's possible, we get on through. So this is our catheter position while isolating the pulmonary veins. And I think this is one of those shots that I just really love. You've got the ASD occluder telling you why you're doing it this way. You've got the duodecopolar catheter sneaking all the way up and around, coming through this azygos. And we've managed to get a good stable position within the right pulmonary veins while we did some of our mapping. Additionally, you can see with catheter placement here now flipped over to the left pulmonary vein, you can see that we don't really have any kind of impediment to the catheter itself. You don't see a bump. You have a nice smooth curve running the wall. We know we're free of the papillary muscles and through the mitral valve. One of the things that really can complicate this is you spend this time, you work your way through, you finally get a good position of support within the left atrium, and at some point you have to come to the anterior positions. The anterior positions require some careful navigation though. As the vector becomes inclined more towards the mitral valve, the catheter is going to attempt to return back to the left ventricle. So one of the things we've done in this case is we took a nice loop here, knowing that we had the space to do it. We advanced that loop into the body of the left atrium to maximize our support so that when we come anteriorly, especially anteriorly and to the left side, we can get good positions, good catheter stability, get those burns in and get our isolation in without dropping too many times into the ventricle. We did lose our position twice. With each time we found it relatively easy to come back across and find ourselves back into the left ventricle or left atrium through the mitral valve. Just by, again, using our FAM and knowing where the edges of our mitral valve are from our map originally, we could really avoid walking too close anteriorly. A couple images from the console side. Here the stereotaxis, what they get. Images demonstrate our areas of the pulmonary veins that we've mapped and our antral ablation lines for isolation of AFib. Orange areas are obviously the demonstration of our RF energy in the Navigant workstation, and that's our watt seconds timing, just showing that we've got pretty good burns, got our time in there, good impedance drops. Cardio visualization, it gets a little interesting on the cardio side just because we've added I took away the map here of the mitral valve, a little bit of positioning there just to get our final product. From an operative point of view, this procedure time was only 118 minutes. So pretty close, not too much longer than our normal transeptal approach. Our patient tolerated the procedure well without complication. We achieved hemostasis post-procedure with manual pressure both of the venous and arterial sites. Our patient at 1 year follow-up remained in sinus rhythm without antiarrhythmic drug therapy and has been feeling well. So talking about the approach. The approach demonstrates a means of left atrial access using magnetic navigation that couldn't be performed necessarily with manual catheters alone. It's a sometimes necessary alternative for pulmonary vein isolation when a traditional transeptal approach can't be performed. Despite the circuitous route to get to the left atrium, catheter manipulation can be easy and predictable. We were using the stereotaxis RMT thermocool for this case, and we can allow for a reasonable procedural time, only 118 minutes in this case. Mapping the left ventricular mitral surface allows for improved manipulation in achieving transmitral positions and reduced expected procedural time. The catheter was generally stable. We got predictable lesions based on impedance drop and vein isolation. Just want to say thank you, a big thank you to Dr. Rafael Corbisiero here at Deborah Heart and Lung, and the Stereotaxis team for the opportunity to present today. Be happy to take some questions. A few shots of just some resources here, looking at some of the other literature search.
All right, Adam, good job. You came out swinging. That's a pretty cool case. And so I have a couple of comments, and then, yes, I want to open it up for questions. So what I think one of the super helpful things about these types of presentations is that certainly during fellowship and even as an attending, you'll see cases that are rare and that you won't even know, you may not have seen it, or you may have only heard of it. We had one interrupted IVC patient when I was a fellow. And then as an attending, I had a patient on the table. You know, the first thing I always do is put intracardiac echo up. And every time I was imaging, I just kept imaging a vessel. I was like, and I'm trying not to fluoro. And then when I step on the floor, I'm above the heart, and I'm like, good Lord, where am I right now? And found that ice catheter came all the way back around to be able to get into the right atrium. Patient had an interrupted IVC. I was not in the stereotaxis lab at the time, and I wasn't sure really what to do. So I ended up canceling the case. And so I think that from my standpoint, for you guys, it's important that if you discover a case like this on the table, you haven't really talked to the patient about doing retrograde aortic access or access from above. Be smart. These are elective cases. In this case, I canceled the case, put the guy on TCASIN, and then, we ended up doing a superior approach. So my good buddy Pasquale, he actually started to do these cases from a superior approach. So in this case, you have two things going against you. One, you have an interrupted IVC and you have an Amplatzer device. So we've also published at Penn, you can cross these. A lot of times there's a small sliver underneath the Amplatzer device that you can go low and posterior and cross, doing a single transeptal, or you can cross through. But if you're doing it from above too, it's a bit harrowing, and I agree with you. I wouldn't be thrilled about doing it. And so clearly this case could only be done with magnetic and with stereotaxis. And so it's a really good example of it. The other, so I think ICE would be particularly helpful, and sound, as you had mentioned. When procedural planning, if you're not going to use that, then I think a CAT scan can also potentially be helpful. I don't tend to use cardiac CTs for any of my cases, with some exceptions for maybe reconstruction of ventricular anatomy and coronaries, but for the most part, I don't. But this would be particularly helpful, especially if you're not sure what's going on. The other comment that I would make is not so much for this patient, because he probably is PAF and just needed posterior wall pulmonary vein isolation. But we've started a hybrid AFib ablation program at Penn, in which the surgeons can get epicardial access from a small incision, and basically do some of the isolation of the veins and towards the posterior wall and isolate the left atrial appendage, which may be helpful in patients who are longstanding persistent, not this patient, but other patients. And the surgeons can do a good percentage of the work for you, because 2 hours for this case is phenomenal, by the way. It's a very good job, but this is a long day regardless, depending on the patient's anatomy. So I think, again, my point is, obviously this is a magnetics and stereotaxis course, but use every tool in your toolbox. Think about anything in terms of options. And this is a very good example of how sometimes a straightforward PVI AFib ablation turns out to be certainly more difficult. But no, I think it's an excellent case and presentation. The only I think I probably would have gotten either subclavian or IJ access to put ICE in, just because I'm so dependent on intracardiac echo. You are correct in terms of being able to have the ICE reach all the way around. I don't believe that it will, even with a long sheath, if you wired it all the way around it. And so almost always the azygous course coming all the way up into the SVC and dumping back into the right atrium is too difficult. And so in those cases, access from above is required. Interestingly, EPs prior to my generation did everything from above. So they're perfectly fine with doing this kind of stuff. They put all their access catheters in from above, which is also why they're really good at IVs, because they put all their CSs in from above.
Right.
While we didn't. And I never did one, not a single one. And so that's when we first started doing some of these cases. It was a little bit harrowing in the beginning, but only other sort of couple of tidbits. But I do want to open it up to other folks on the call in terms of questions, comments, really anything at all. But I think it's a really phenomenal way that you can think out of the box and use, like I said, every tool in your toolbox.
Yeah, well, I think this is one of those ones where you're really happy to know all these things ahead of time. You can plan ahead for the ASD, you can plan ahead for the IVC. With Dr. Kazemian, I've done 1 or 2 crossings of an ASD closure device, and it always seems like you have to put a fair bit of force to work your way through that, which without the support, even from above, I think that would be a little harrowing. I'm not looking forward to doing that on my own.
I wouldn't do it. And so, yeah, I agree. So as you guys already know, you can get transhepatic access. IR can usually help with that. And it's also a potential option to be able to, for a patient who just has an interrupted IVC, not a combination of an interrupted IVC and a Amplatzer. And so that's another option for, it requires some partnership with your IR colleagues, but it is doable. And we've certainly done those cases at Penn as well.
Interesting.
Any other comments, questions, anything at all, guys?
Okay, I'll be happy to break my sharing here for send it back to you.
Great job, Adam. So, all right. So, Vivek's next.
Yep. Oh. And
It always makes me, every time I see PGY8, I'm like, wow, we did 8 years of training and we're not neurosurgeons. It's kind of crazy, but anyway, that aside, that's how it goes, right? But sorry to interrupt. Go ahead, Vivek.
oh no, not at all, not at all. All right, can everyone see my screen? I guess you can because you saw the picture. Okay, sounds good. All right, my name is Vivek. I'm an EP fellow at KU, and thanks to Stereo Texas for this opportunity to present. And the attending physician on this case is Dr. Seth Sheldon, who helped with this presentation as well. So disclosures, I don't have any disclosures to present. So our basic history was, this is a 38-year-old female who presented with no significant known previous cardiac history and was referred to cardiac electrophysiology at KU due to a history of ventricular tachycardia. She was a previous long distance runner who developed cardiac symptoms with prolonged running, prompting a cardiac workup at an outside facility. Subsequent workup did reveal episodes of sustained and non-sustained VT, which was monomorphic, and she was placed on nadolol therapy for management of VT. So some of the pertinent findings in terms of imaging that she did have a structurally normal echocardiogram in January. There was a Holter monitor performed in March showing several episodes of non-sustained VT and an episode of possible sustained wide complex tachycardia as well, which appeared to have a similar morphology to some of the PVCs the patient was having. There was an MPI stress test performed, which did show what they thought was potentially reversible apical and distal lateral wall defect. We did also have a cardiac catheterization performed, which confirmed no evidence of epicardial coronary disease with some slow flow in the coronaries. There was a cardiac MRI as well, which did show overall a normal LV and RV function. Post-gadolinium delayed enhancement did reveal evidence of lateral wall, anterolateral and inferolateral subepicardial abnormal delayed enhancement, consistent with a non-ischemic pattern of myocardial fibrosis/scar, and likely representing a sequela of prior myocarditis. They did also have a cardiac PET, which did not reveal any evidence of myocarditis or cardiac sarcoidosis. And in summation, these findings appeared to be likely consistent with non-ischemic cardiomyopathy from likely burned out myocarditis, which was not active. So this is our baseline EKG. It appears to show sinus rhythm. There appears to be non-specific T wave inversions across the precordium. And there was a PVC with the right bundle branch block and a right superior axis present. So in terms of our setup, we did opt to use general anesthesia. We did a subxiphoid epicardial axis with anterior approach and a steep left lateral cine imaging to confirm our location with contrast, as well as a short Agilis sheath. Right femoral arterial axis was obtained for hemodynamic monitoring. We did utilize intracardiac echocardiography. CS catheter placement was placed from the groin and a diagnostic RV catheter as well. We did perform transeptal puncture and endocardial LV mapping after having performed epicardial mapping, and mapping was performed with our Cardo mapping system. We utilized the Penn mapping catheter and the RMT catheter with Stereo Texas. A coronary angiogram was also performed at the conclusion of the case. So there were a couple different PVC morphologies noted. On the left-hand side of the screen, you can see sinus rhythm, and then you can see a PVC, which appeared to have a right bundle branch block, right inferior axis, On the right-hand side of the screen, you see sinus rhythm, and a separate PVC morphology was noted with the right bundle branch block, left superior axis. There were short non-sustained VT episodes noted with different exit sites with aggressive extra stimuli. And on the left-hand side, you can see a left bundle branch block, left superior axis morphology. And on the right-hand side, you can see a right bundle branch block, right superior axis morphology. It is interesting to note that on the right-hand side of the screen, perhaps the first beat after extra stimuli does appear to have a morphology similar to this morphology, but then it transitions into a different morphology. So here at our arrow, you do see when we're performing some epicardial mapping that you do see an arrow which points to a late potential in sinus rhythm. And over here we have, during RV pacing, we performed an epicardial map with the Penn mapping, with the Penn catheter. And on the right-hand side of the screen, you can see our epicardial map. And on the left-hand side of the screen, you can see an endocardial voltage map. And overall, the endocardium did appear to be healthy, but you can see during RV pacing that we had significant scar in that apical lateral region. And we'll kind of go into this a little bit later, but we had a presumed possible critical isthmus. So over here, we have, again, our epicardial map, and we have arrows pointing here to, on the top screen, you notice that late potentials and continuous EGMs respectively. So here we appear to have a late potential in the Penn catheter, and here we appear to have continuous EGM. And this is during RV pacing, endocardial RV pacing. So over here, you note a late double potential on epicardial voltage mapping during RV pacing. And we measured from RV pacing to the latest double potential was around 114 milliseconds. So here we have a propagation map while the patient is being RV paced. And you can see that as the wavefront proceeds from septal aspect towards the lateral, it appears that there's kind of a delayed coalescence right around that potential critical isthmus. But this is during RV pacing. We weren't able to induce sustained VT to perform mapping, but our mapping was done during RV pacing. And we have a ripple map here showing kind of a similar finding, and you note sort of a delayed delayed wavefront appearance right in that suspected potential critical isthmus region. Here we kind of combined a ripple mapping with our voltage mapping, and you can sort of see it correlates to that same location. We also again measured our late potential there. So utilizing our epicardial axis and then subsequently utilizing the RMT catheter, we were able to accurately navigate and get to that kind of inferior apical and apical lateral scar. And significant ablation was performed around those regions which were described on the mapping earlier. As you can see now, we are RV pacing, and you no longer see any late potentials, which are no longer present. And utilizing stereotaxis and the RMT catheter, we were able to manipulate in that region without any difficulty. Here, we showed a fluoroscopic appearance of a coronary angiogram. This is actually performed after our ablation. We were pretty confident that we were away from the coronaries because it was an apical lateral region. And if anything, it would have been a small branch of a small tributary of a major vessel. So we actually performed it prior to coronary angiogram. But here, this is just sort of a coronary angiogram showing you the tapering location of the LAD and other coronary vessels. So in summation, we were able to target regions of late potential and continuous fractionated electrograms. and targeted in addition to a presumed critical isthmus. Utilizing stereotaxis, we were able to get to this region without any issues, and it helped in terms of navigation. Aggressive ventricular extrastimuli was performed at the conclusion of the procedure with no induction of VT, with isopril of up to S5 with a baseline drive train of 600 milliseconds. High voltage pacing was unable to capture in the regions of ablation. Ultimately, catheters were removed and the epicardial drain was pulled out without any complications. We did elect to implant an SICD the following day due to a history of VT and subepicardial scar. No repeat ventricular arrhythmia episodes were noted on follow-up. And the question kind of became, should the patient essentially be allowed to run again? So we did ultimately perform an exercise stress test, and no induction of VT, non-sustained or sustained, was noted on that study. And that marks the conclusion of our case. Thank you very much. Thanks to stereotaxis and to our local cardio mappers.
All right, good job, Vivek. Another great case. I got a bunch of comments. Again, really interesting. I was hoping that you would bring up the idea of the defibrillator because I was scratching my head the whole time. I'm like, man, I'm worried about this girl, even though by definition, she's got a normal EF, she didn't have syncope, but she's got scar there. And, you know, I know we feel that everything we do in our field is 100% successful, but the last thing you ever want to see is one of your young patients die suddenly. Trust me, I've had them, and it really does rock you to your core. You know, we sort of take for granted, especially during fellowship, how sick our patients are and how high the stakes are. And in this case, you know, in particular, I think that we talked earlier about pre-procedural planning. Great job with cardiac MRI, trying to figure out exactly where you were going to be targeting, right? Because if you didn't have plans for epicardial access for this patient and talk to her about it up front, your endocardial map was completely normal. What would you do? Nothing. And so I didn't see the unipolar map, but my guess is that it would have given you a hint that there was scar there on that lateral apical border if you changed it to uni settings. Just keep that in mind. If you go into a case, you do a bipolar map and it's completely normal, make sure you look at the unipolar in particular for non-ischemics. And so I think these cases are great for stereotaxis. One, if you're having very rare PVCs. And I have a partner that makes a comment, says, I'm not sure if we'll get back to the spot again. Well, you never have to make that comment with stereotaxis, right? You can always you can sit, you can wait for 30 minutes and check your phone and drink your coffee, at least pre-COVID, until you get to that spot again, until the PVC comes back again. And that's certainly very beneficial. Epicardial access and or mapping. There's all sorts of new ways to do epicardial access. Again, I mentioned my buddy Pasquale and a couple of other people have done where you can insufflate CO2 into the epicardium by perforating a branch of the AIV and get access that way. There's lots of other ways. You use micropuncture or otherwise, but mapping in the epicardium and ablation in the epicardium is also great with a stereotaxis catheter. It just sort of smoothly goes like a wet noodle. You guys have known who have done these cases. This catheter is the safest catheter you could ever use. And the last thing you want to do is cause harm to a young, healthy person. I do very much believe in the use of multipolar mapping for these cases. Again, you can do a map with the bipole of an ablation catheter, but it's pretty big. And if you're really looking for those areas of fractionation, I like Penn, though it does cause a good amount of ectopy in the endocardium in particular. Decanab is a great catheter if you're going to use cardio for these cases to be able to map in a very similar way that you would maneuver a catheter either in the epicardium or endocardium. I use it all the time. If you're going to use Navix, again, you don't have to use one system. Obviously, Rod Tung has published, and many people have, about looking at ILAM and areas of delay, which you sort of showed with that ripple map. And again, you can use the grid. Cardo's coming out with new catheters. I'm sure you guys know about Uptrail, and it sounds like the ectopy with Octaray is less. So lots of options in terms of mapping and being able to build. There's one other thing that I wanted to mention to you guys. Again, it's always important that you get exposed to every new type of technology and options. So Stereotaxis and myself have partnered with a company called Vivo, which is essentially a company in which they took 10,000 cases plus of PVCs and VT, and they basically use their maps and they put it into AI and machine learning, which I think is going to be the future of our field in many ways. And they used it to predict both PVC location and or exit sites for VT. Now, I spent years at HUP, vacillating over where a PVC was coming from or where a VT was coming from. So I'm pretty good at doing that. That being said, it's really nice to have a software program that says this is where it's coming from. And we've only done a small subset of cases, but it's correlated very well with both activation and or pace mapping in cases where you have non-sustained ventricular arrhythmias that you can't sustain, like in this case, or very rare PVCs that you don't have enough time to be able to activation map. So the way it works is it's patches that you put on the patient, just like Cardo or Navix patches. And then if the patient has any extra heartbeats, you have to have a reconstruction, either a CT or MRI. In this case, obviously you had an MRI. And then that builds into a software program that integrates with stereotaxis, and it actually maps a single heartbeat. And it's pretty fascinating. I can't say that the jury's not out per se, but I've had cases that have had both endocardial and epicardial. Like I had a non-compaction case recently that had 6 different PVC morphology. I was able to predict each one. And it's a nice tool. So my point is, there's all this new stuff that continues to come down the pipeline. And when you guys get exposed to all this stuff, either at HRS or at other conferences or in conferences like this, where we talk to each other and learn from each other, it is an option. And this would have been a good case for that. It would have basically predicted where you guys already went anyway. But again, just something to keep in mind. And then the last comment I'll make is that exercise and telling patients like this that they can't exercise is one of the hardest things that we have to do, especially for people who are long distance runners, triathletes, etc. Telling them the exercise, good luck to you, by the way, they're going to do it anyway. But I like the idea of doing at least an exercise test. Someone, like my mentor, Dr. Marsalinsky, would say, you fix the problem. So let them go back to doing what they're doing. Plus you put an SICD in anyway. So the worst that happens is she gets shocked. But anyway, overall, excellent case, great job. I think that just again, same idea. Use every tool in your toolbox, every piece of information that when you get into doing the case, you can have the best results possible. So, but great job, Vivek.
Awesome.
Thank you for the helpful comments, and Vivek, great presentation. The one thing I do want to add about the exercise study too, another thing that was helpful about that, and one of the rationales for doing that was also to assess sensing with the SICD. So we had the Boston Scientific reps there and wanted to make sure there wasn't double counting and over sensing that was happening with exercise. Because the last thing we want is an inappropriate shock too in a young person or anybody.
Agreed. I know that they've said with their algorithms, they've certainly improved in terms of T-wave oversensing, but I still see it, and I agree completely that, and certainly someone who's gone through what she's already gone through completely healthy prior to this, that's the last thing you want. But the nice thing is, at some point in time, which who knows what that would be, if you feel comfortable, you can take it out, which obviously is a little bit more complicated with a transvenous device. All right, any other comments at all? Otherwise, we'll move on to our last case. No pressure, Paul. 2 solid ones so far, so you got this.
Hi, can everybody hear me?
We can, yes.
Yes. Hi, my name is Paul Madaj. I'm one of the I'm also a PGY8 over at Mount Sinai, Morningside, in New York City. So I'm pretty much going to echo a very similar theme to what was mentioned in the previous 2 cases. Before I get to the ultimate goal of my presentation, I'll first also just start off with a case. Why does this not want to? Here we go. First of all, I also have no disclosures. I would also like to give a special thanks to Mason Zilka, who's our local Stereotaxis rep, along with the whole Stereotaxis team for their dedication to education, patient care, and their support for fellows. Starting off with a case, we had, this is a case of a 56-year-old female with a history of coronary artery disease, status post-CABG, hypertension, hyperlipidemia, diabetes. She has been experiencing palpitations, increasing in frequency and occurring predominantly during evening hours. She has attempted beta blocker therapy along with antiarrhythmics, but has been intolerant due to becoming 1, bradycardic and 2, hypotensive. She came in for evaluation in clinic. She denied any chest pain, but just mentioned when she gets these palpitations, she becomes extremely dyspneic as well. And her symptoms are worse with exertion. She had an echo performed. Echo reveals predominantly a preserved EF. LVH present, left atrium dilation, but no other real standout abnormalities. Cardiac cath, as we know, she's got disease present. She also does have a history of cabbage present, which does add to her. I mean, the initial thought was that it would add to, it is worth evaluating to see if she does have coronary artery disease or recurrence of any type of significant stenosis, which she did not. This was her initial EKG present on presentation to clinic. As we notice here, it's a bigeminal pattern. V1, V2 R waves are upright. We do have including V3, we do have a transition V3, V4. Leads 1, 2, and lead one is upright positive. Leads 2 and 3 are negative during the PVC burden, pointing more towards a posterior papillary picture. We did do the first EP study. Initially, we assumed her PVC ablation was successful. Her PVC, as mentioned, was localized to the posterior medial papillary muscle. The one issue I could describe that we had during the first ablation, I mean, we did use Navix echocardiography. We did go transeptal. And we did use extensive fluoroscopy present to help guide ablation. There was one thing I want to note is that there was extensive instability present with the RMT catheter during the initial ablation attempt. But despite the instability, we still felt we had a successful, we still had a successful outcome initially. 1 hour later, return of bigeminy and return of symptoms. So the question now was what to do with this patient. So we talked with the patient, and we did tell the patient that we want to give it a second go around, do a repeat ablation. She came for follow-up. She still continued to have persistent symptoms. So at this particular point, as mentioned, is what can we do differently? How can we obtain catheter stability? And there was even the possibility of using cryo. As we know, with cryo, we apply the initial lesion. With freezing temperatures, we obtain stability due to the catheter sticking to the tissue, and hopefully that we thought that could have been a potential option. We proceeded with the second ablation. As mentioned, we used Navix as the mapping system in this particular case. I know we've had several cases present with Cardo today. On top of that, we used Navix echocardiography to help guide us. We went transeptal. It was more of a mid-septal puncture going into the left atrium, and then from there guiding the catheter into the left ventricle. We did obtain once again, we did once again obtain localization, success, high. We did obtain significant matching of the PVCs, about 94% on Navix, which would correlate to about almost 100% using the Cardo system. And we applied once again radiofrequency ablation lesions. As we can see here, the posterior medial papillary muscle, extensive lesions applied from the tip to the base. And we can see here, this is our last PVC prior to applying radiofrequency ablation therapy, which did allow for termination. So what we utilized in this particular case is, and one thing that I really want to hammer home, just as mentioned in the previous cases presented today, is the utilization of all tools available, especially in the lab. We were able to, as we can see here, we have the RMT catheter in the left ventricle, but at the same time, what allowed us to obtain stability was actually ICE echocardiography. And that's one point that I would like to make. And this is probably the most important point, is to utilize all tools available at your disposal in order to maintain that catheter stability, to be able to apply radiofrequency ablation lesions and obtain a successful result. We applied 1 minute lesions at 50 watts. We obtained great impedance drops, which eventually did lead to termination of the PVCs that the patient had previously. Post ablation, here's a short video just demonstrating catheter stability during radiofrequency ablation lesions in correlation while under fluoroscopy. As we can see, we've had great stability, very minimal movement as comparison to our first case. This is our final result post ablation. As we can see, no PVCs present. Post ablation ECG, and also this is present at follow up in clinic. No PVCs present. Patient is completely asymptomatic, returning to her previous quality of life. So the differences that we wanted to mention, we've had better visualization, especially with the use of echo and fluoroscopy, especially the echo part did help us attain better visualization and stability. We did use, as mentioned, we did go mid transeptal. We did use a Magellan sheet, and that also did help provide us with a certain degree of stability. As mentioned, power delivery was 40 to 50 watts at 60 seconds, 10 to 20 ohm impedance drops, and lesions were successful from the tip to the base. Once again, I know maybe this case wasn't, I guess it provides a good correlation between the cases presented earlier. And once again, we wanted to hammer home the point that use all tools present at your disposal in order to obtain adequate results. Thank you very much. And I'm opening the floor to questions.
All right, Paul, good job. Another good case. I have a couple more comments, and then we'll open it up for questions. PAP PVCs are either the most satisfying case you'll do as a PVC or the most miserable case that you'll do in the entire, in your repertoire of cases. I mean, I'm like high-fiving people. We got it in 5 minutes. And then you have the other side. We're like, why can't we get this? And so I like the comments that you made in that when you bring a patient to the lab who's had a previous ablation, either with you or with someone else. I get a lot of referrals from other places that have had a failed previous procedure. You need to ask yourself, what are you going to do differently? In particular, if you're going in for a second case, either that you did or someone else did, you should not assume that the other guy who did it just wasn't that good. Because if you do make that assumption, you are going to be struggling. Trust me, we're all really good at this. We all spend a lot of time. You all have 8 years of training before you even get out into the world to be able to do this. So it's as particularly important. And so for PAP PVCs in particular, I mean, you think about it, stereotaxis is perfect for these cases, right? Because the heart's moving, right? And you're trying to hit an intracavitary structure. I don't care how good your hands are, you can't keep it moving, but the catheter will just sit there and move with the heart. And so for PAP PVCs, and honestly, I think for all PVCs, whether they be epicardial, AIV or MCV, outflow tract, RVOT or LVOT, where you have to get to other side of the valve. I have tons of cases in which I've been able to prove this. Now, when I first started doing these cases, I'd map it, and I was somewhat hesitant to use stereotaxis, and I did, and we weren't able to get the PVC to go away. And I said, oh, it's got to be the catheter, right? Carpenter always blames his tools. And so then I switched out for a manual catheter, and same result. And and I felt like I was not gratified at all by switching to it. So my point is that for people who think that it's because of the catheter, that's not that. It's either that just as you had mentioned, you're not getting stability. So I think I'm very heavy ice user. I do almost all no fluoro or low fluoro stuff. And in this case, I think that sound would have been really helpful when you're doing sound shells for PVCs in particular. Spend a lot of time drawing out the PAP, each head of the PAP. And I would also recommend, I've found more so than not, either for LVPAP or even RVPAP moderator band, if you see like something abnormal, like a calcification or a cord, something that looks strange, draw it out, keep a look at it. And that's particularly important. And the only drawback we don't have a good way to move the ice catheter around when we're doing ablation, right? You're in the control room and the ice catheter, unless you have a fellow that you can make go do that while you're doing it. And so if you don't have that, sorry guys, then you're kind of on your own, which is what I am for the most part. We have cardiology fellows rotate in the lab, but not our EP fellows. They're at the mothership at HUP. But what I'll generally do is, before I break scrub and bring the magnets in, try to put the ice catheter where you think the PVC is coming from, right? So if this is posterior medial anterolateral pat, get it to there, maybe put a little bit of lock on it, put a towel on top of it so the ice doesn't move. And
That's
then
exactly what we did.
and then just leave it there, right? And so that's one way to do it. But sound for me is particularly helpful. I think you should very much get exposed to all of the mapping system, all of the catheters, all of everything, because when you sort of put yourself in and using 100% of one thing, it pigeonholes you in terms of a doc and be able to use technology, but also for multiple other reasons, whether it be partnership with industry, research, clinical trials, new technology. It's important that no matter what, I'm even talking about implanting devices or anything that you guys do, you really should diversify and learn, because each system is different and you can learn something from one that helps you apply it to the other and vice versa. And so I think I have no problem with either using Navix or Cardo or whatever mapping system you want to be able to use for these cases. Cryo is an interesting one. And so we did, prior to me using stereotaxis, I did use cryo for these cases. Same kind of concept, like in A Christmas Story where he gets his tongue stuck to the pole. It's the same concept, right? It freezes and then it just doesn't move with it. It's quite a stiff catheter, and it is not meant for mapping per se, especially an intracavitary structure. So you'd have to map with an RF catheter or a something else and then switch out for it. But it does work, and I have a couple of cases that I did while I was a fellow. But honestly, with the use of robotics, that's not really been the case. The only other thing, so we talked about mapping, we talked about being able to stability, to be able to get to where a spot is, right? This patient has a CABG, so you're not going to be able to go epicardial anyway. PVC cases don't generally, for PAP, don't generally come from the epicardium, so I wouldn't expect that would be the case. But it's a thick intracavitary structure. It's really hard to penetrate to. And so delivery of energy, for lack of a better term, burning the crap out of it is generally what's required. So you did the right thing in terms of starting high, right? I'll start these cases right at 50 watts. Usually what we talk about in terms of a corollary between a manual catheter and an RMT catheter is about 10. So if I was going to do it 40 watts to start with, I'd start at 50 watts. I wouldn't go above 50 watts, obviously. And then half normal saline is the other thing you can consider. I've done it. I can't say that I've had the greatest efficacy with it, and you will get steam pops. You have to be very careful, but it is another way. We're just trying to deliver more energy right to the area of the PAPs. Now, PFA is coming down the pipeline. Will that be the future? Can we dial up PFA to be able to deliver lesions that are even more so than RF? Maybe, hopefully. I sure hope so. I ran the clinical trial for FARAPulse here at Penn, and I'm going to be doing the next one with Biosense, and it's super exciting. And I think that Stereotaxis has continued to partner with many companies. They are very open to that, and I'm excited for the ability to potentially deliver a pulse field ablation. I mean, that and left bundle pacing, if you're on Twitter, that's all you're ever really hearing about. But I think that those two things are exciting. You guys are coming into our field at a very exciting time. Like, everything keeps changing. Nothing that I do now is the same as when I was as a fellow, and that was only 7 or 8 years ago. And it just keeps changing. So if you like the idea of new stuff and being able to continue to reinvent yourself as an electrophysiologist, you picked the right field. I mean, Dave Callens told me, Ben, if you are not comfortable with change, you're going to become a dinosaur in this field really quickly. And he's right. And so I think that, be engaged, learn, don't, try to feel comfortable with being uncomfortable, because every time you do something new for the first time, I mean, I didn't learn to do left atrial appendage closure as a fellow, and I do a ton of it now, but I was scared as hell when I first started. And so, it is, you guys had the chance to get exposed to everything during fellowship and continue that, throughout the course of your training. But beyond, it doesn't mean that you're not going to continue to learn once you become attending. It doesn't shut off. You're going to keep learning, be exposed, engage with each other. I can't tell you how many people I met at conferences, either like this or in person, people I met at Joseph's and Wellens that I still talk to, and we still bounce cases off of each other all the time. I mean, you think that beyond the actual learning of cases, just people meeting each other and learning, and I'm happy to pass along my information and think in general, that's how we learn from each other and we get better at this, is that we teach each other. So I think that those are my comments. I want to open it up to anyone else who has any questions, comments, anything at all, before I let you guys go on with the rest of your weekend.
Hey, Ben, Brad Basic here. Can you hear me?
Hey, Brad, how you doing, buddy?
Doing great. So,
by the way, Brad was one of the people who encouraged me to start using stereotaxis when I was a fellow becoming attending. So I used to moonlight for him back in Torsil. So I thank Brad.
your joints and your back thank me.
Exactly.
So just a pearl for everyone, because I think getting the RMT catheter to sit on the papillary muscle is a challenge. So we have to remember, think out of the box and use all the tools in your system. So first of all, get some great ICE images with the PAP that you want to focus on. And then make sure that your mapping representative, for most of the time it's your cardo guy, puts the actual fan of the ICE image onto the map, so you can see where it is and where it cuts. Now that will show you exactly where that fan is. The other thing you do on stereotaxis is you rotate your image so that it matches the screen on cardo, and then there is a function on your active screen, if you click the mapping button, you could link the cardo and stereotaxis screen to be in the exact same view. So if you line up your ICE image, because a lot of people have a static ICE image active moving with the cone facing down, make the cardo image with the cone facing down, and you see where that slice is with very slight movements, when you will be able to use all three screens to align yourself very easily. So you'll know if you need to go right, you go right. If you need to go left, you go left. And if that's all lined up, that makes getting on to the PAP and knowing where you need to manipulate very, very, very easy. Saves hours. The only other thing I would say is map from the tip of the PAP down to the base, right? If you haven't mapped a lot on the PAP itself and you think it's early at the base, well, the signal looks great, and then it really fans out at the base of the PAP. So take your time to look for something early on the PAP. It sometimes saves you a lot, rather than making scorched earth, which a lot of times has to happen, but nonetheless, those would be the pearls. Especially lining all of the images up, you'll really be able to find and manipulate very, very quickly.
Yeah, I agree, Brad. I think that for these cases where you need to sort of meticulously map an area that's difficult to map, I mean, I don't care if I'm spending, 30 minutes trying to map one PVC, if I'm sitting down and using a mouse to be able to do it, as opposed to, just as Brad had mentioned, wearing lead. And these can be long cases, VTs, burning scars for hours, long cases. And listen, as you guys continue to go up in age, it doesn't get any easier. And it, just as we had mentioned, our backs were not designed to wear lead for this amount of time. And my boys are only 2 and 5. I got to do this for a lot longer to get them through college. And so I think that take care of yourselves. I didn't really learn that during fellowship, and I had to learn it as an attending, that, it's your responsibility. Unfortunately, we've lost many EPs to cancer and to other sort of things that have clearly been associated with radiation, and, be smart about it. I think we're doing better about training this, current generation of fellows to do that kind of stuff. But stereotaxis makes it so much. I mean, that's a no-brainer that you don't have to, you won't be floored at all. The risk to the patient is minimal, but to us who are going to do this for decades, it's a big one. So any other comments or concerns? Otherwise, I'll let you guys go enjoy the rest of hopefully a beautiful weekend.
Hey, one last thing, Dr. Souza. First of all, thank you so much for your leadership and leading us through this group. Thanks.
This was great. I hope that we can do it again soon.
Yeah, absolutely. Thanks to the fellows, to Adam, to Vivek, and Paul. Great presentations all. Thanks for the comments from the attendings that were on Dr. Basic and Dr. Sheldon. And I guess just a shameless plug for the Robotic EP program for the fellows. These guys are amazing. We get to work with them every day. They really are, what's great about the future of EP. And for the attendings that are present, as hiring opportunities become available, consider the fact that we have exposure to, 25, 30 fellows any given cycle that are really the best of the best. And, reach out to your Stereotaxis leadership as you consider hiring folks, because these guys do the most complex, the most technical work, and we're super proud that they're associated with us. And that's my last thing to say. Thanks, y'all.
Thank you for the opportunity.
Thank you very much.
Everybody. Take care. Good luck with the rest of your training, and enjoy the weekend. Okay.
Thank you very much.
Thanks so much, everyone.
Thanks a lot. Have a good weekend, guys.